welcome. My name is Samantha. I'm a registered nurse and a student at BCIT. Today we're going to be talking about breastfeeding. So we're going to talk about Sherry's case. Sherry had a healthy pregnancy. She delivered at 41 weeks of her first baby boy, Joey. Joey's been healthy, but Sherry has inverted nipples and needed some extra support. And now she has also learned that Joey has jaundice and he's 6 days old. So how might we support Sherry and Joey with her inverted nipples, you might ask? First, let's start off with talking about what inverted nipples are. So inverted nipples may be flat or completely inverted and can cause breastfeeding difficulties, as seen here in the diagram. It's suggested inverted nipples are caused by bands of adhesions attaching to the inner layer of the breast tissue and pulling the nipple back in, or it can be due to short lactiferous sinuses. So let's begin first with our patient by examining the nipple. We might encourage the mother to roll the nipple between her thumb and her index finger and in an attempt to erect the nipple. We could also apply a cold compress or attempt the Hoffman's technique. So I'm going to show you the Hoffman's technique here. So as you can see on the diagram, the Hoffman technique suggests you place your thumbs or fingers on the opposite sides of the nipple, making sure they're inside the areola, close to the nipple. You want to firmly but gradually pull away from the nipple in an attempt to erect it. This may be done up to 5 times a day before feeds, and it can also help long-term with breaking down some of those adhesions, and the mother may not have to do this as often. All these methods can be used together to facilitate breastfeed. So cold compress, trying to roll the nipple out, and Hoffman's technique. Also, to support Sherry, we would encourage her that most infants are able to feed, and the infants don't nipple feed, they breastfeed. So often the infant will still have an effective latch even if her nipple isn't fully erect. I would encourage Sherry to breastfeed more often and teach her about infant cues, about feeding when the infant Joey is in his alert and awake stage. And we also might want to promote skin-to-skin contact and explain the importance, Sherry, that generally it takes all mothers 4 to 6 weeks to establish breastfeeding, and to be patient. It's a natural process, and her and Joey are going to get there. So in your discussion with Sherry, she mentions that one of her friends used a nipple shield for her inverted nipples. What would you tell Sherry? Personally, I would explain to Sherry that often women are able to breastfeed with inverted nipples and do not require the breast shields to do so successfully. Adding that nipple shields are more difficult to ensure proper milk transfer has happened and often do not allow the breast to fully empty. So often moms end up stopping breastfeeding earlier and weaning earlier than they intended to. And if she'd like some extra support, you're more than happy to help her and also set her up with a lactation consultant upon discharge. Some key points for Sherry are also that often with supporting skin-to-skin contact and attempting to latch, the infant can occasionally draw out the inverted nipple themselves. I would encourage Sherry to continue hand expression and potentially pumping until the infant is able to latch. Often women are still able to pump and hand express their milk even with inverted nipples. So Sherry and Joey are doing great. We're noting appropriate milk transfer. Her and Joey are bonding well. However, Sherry expresses to the nurse that she's quite worried that it's been so difficult to start breastfeeding, and now she's been told that Joey has breast milk jaundice. There are 3 types of jaundice babies can get. The first one is pathological jaundice. This is liver disease. It usually occurs within the first 24 hours of life. You'll see the bilirubin spike. It absolutely requires intervention and treatment. The second type of jaundice is physiological jaundice. This occurs after the first 24 hours of life. Sometimes this can be because babies in the placenta, they're in a low oxygen environment, and when they come out in life, they're in a high oxygen environment, so it can be just a natural physiological process. The other way we see physiological jaundice is due to inadequate feeds. So often the baby's not getting enough calorie intake. They're not necessarily dehydrated, but they need to continue breastfeeding and get those calories up. We may also consider treatment and additional monitoring for these infants, making sure they're having enough wet diapers, enough bowel movements. The third type of jaundice is the type that Joey has. This is breast milk jaundice. It occurs about day 5 of life and peaks at day 12. We don't exactly know why breast milk jaundice happens. However, it's not a bad side effect. We still want mothers to continue breastfeeding. We just may want to monitor or treat the infant. But we definitely want to encourage and make sure mothers know that it's not because of them. It's not their fault. It's natural. Often 50 to 70% of full-term infants develop jaundice, and about 80% of premature infants develop jaundice. So how are we going to detect jaundice, and what are we going to do about it? Jaundice can be detected by noticing the color of the skin change. Often the sclera will yellow, the skin will yellow. We can also do lab tests to confirm this. We check the bilirubin levels. We might also be looking at their stools or their urine. Often their urine will be concentrated and dark, and their stools might be light in color. What are we going to do? We're going to encourage prevention generally. Hopefully we'll be keeping the baby hydrated and encouraging the mother to feed, keep that calorie level up. However, we can also do phototherapy. Things to keep in mind with phototherapy are we want to ensure that the mother and baby stay together as much as possible. So we don't want to separate them for too long at a time. If it's possible and they don't need Billy lights, then keeping the mom and babe together skin to skin is the best possible option we have, because we want to ensure that the baby's still getting skin to skin contact to keep up with feeds. If that's not possible and there's any other possible way to have the baby get Billy lights and skin to skin contact with the mother, then we'd want to encourage that as well. We're also wanting to encourage and educate the parents what the signs of jaundice look like, when to seek help, if they're seeing the change in stools, if they're noticing their baby's more lethargic, not feeding well, things like that. We want to refer them to get help as soon as possible. So we met with Joey, Sherry, and the doctor, and it turns out that Joey's Billy levels are only slightly elevated and he doesn't require phototherapy. We're going to continue to support Sherry and Joey in their transition by making sure that they have lots of skin-to-skin time, ensuring that the transfer of milk is happening and that she's not struggling with those inverted nipples. We're going to ensure that any other questions or concerns she has before she goes home are answered, and that the two of them are ready to go home. Thank you for tuning in today. I'm so excited that you could watch, and see you next time.
Wish I could reach up and reset that sun, reverse these wheels, go back and re-pick you up. Went by so fast, oh so sweet, make me wanna